हेलो 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 चेक 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 चेक
हेलो
चेक
टेस्ट टेस्ट टेस्ट
हेलो चेक चेक
हेलो हेलो टेस्ट टेस्ट 1 2
हेलो
3
चेक
1 2 3 टेस्ट टेस्ट हेलो 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 1 2 3 हेलो 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 घूम फिर के बात
प्रशांत
बाद में ढूंढते है ना इधर क्या है नीचे देख
हेलो चेक माइक टेस्टिंग हेलो चेक हेलो
हेलो हेलो 1 2 3 4 1 2 3 4 टेस्ट 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 टेस्ट
हेलो हेलो
हेलो हेलो 1 2 3 4 1 2 3 4 माइक टेस्ट माइक टेस्ट माइक टेस्ट माइक टेस्ट 1 2 3 4 माइक टेस्ट 1 2 3 4 माइक टेस्ट
हेलो हेलो चेक हेलो 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 नहीं 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 कुछ भी नहीं सेम है चेक 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 नहीं नहीं हेलो चेक
हेलो टेस्ट टेस्ट हेलो हेलो आवाज हेलो हेलो टेस्ट टेस्ट हेलो 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 टेस्ट टेस्ट नीला बटन बंद हेलो हेलो टेस्ट 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 टेस्ट
Good evening, friends. We welcome you to the broadcast of the PG clinics from the IAP Action Plan 2014, a vision by Dr. Vijay Yevule. You will be noticing a few different things here. We are in a different venue, and we are going to struggle through this evening as far as the temperature and the environment is concerned. But only one thing rings true is our determination to have these clinics going on and on, irrespective of what happens. And that is the spirit that our group sort of pushes forward. So, in spite of us not getting the usual venue, we still continue with the clinics, and I hope you enjoy today's session. A few announcements before we begin with the cases. Next broadcast will be from Kalavati Saran Hospital, New Delhi on the 24th of October, that is one day after Diwali, and it will start at 4:30 p.m. Next Thursday is Diwali, so we will not be having a clinic at Sion Hospital, but the broadcast will be on Friday 4:30 p.m. from Kalavati Saran Hospital, Delhi. We must again express our gratitude to the makers of Azithral, who have made this academic activity a possibility. I reiterate, this is an extremely altruistic activity on their part, and we should really be grateful to them. Should we begin?
Good evening, sir. My patient, 2-year and 2-month-old male child, first by birth order, born of non-consanguineous marriage, Gupta by caste, Hindu by religion, resident of Chembur, come with the complaints of not able to stand, not able to speak. I would like to start with the birth history. MC history. Mother registered at 2 months of gestation. She is immunized with 2 TT injections. There is no history of fever, rash or lymphadenopathy in the first trimester. Mother noticed quickening at the 6th month of gestation. Mother is giving there is a hypertension in the pregnancy. This is a full-term vaginal delivery at hospital with a trained person. Baby passed meconium in utero. Baby did not cry after birth and cried after 5 hours without any intervention. Child was not accepting feed, hence shifted to the child to the NICU, and IV fluid and some injections were given. RT feed started on the day of flight 3rd and discharged after 8 days. Child was not doing well at home and not so active, and poor feeding was there. Developmentally, child achieved head holding at 6 to 7 months of age. Head turns following moving object by 7th month. Sit with support at 18 months. Child able to creep at 12 months, not able to crawling. Sit without support at 2 years of age. Hence, developmental age is around 9 to 10 months. Fine motor wise, child hold object momentarily when given at 8 months of age. Hand regarding at 9 months, tries to reach the object in prone position at 18 months, transfer object from one hand to other hand around 18 months. Mouthing also developed at around 18 months. He is able to throw object at 2 years, and ulnar grasp achieved at 2 years of age. Child is not able not achieved pincer grasp. Child achieves social smile at 7 months, recognized mother at 9 months, mirror smile at 15 months. Stranger anxiety developed at 1.5 years of age, and search for the drop of object at 19 to 20 months. Language wise, cooing is present at 8 to 9 months and babbling at 15 to 16 months. Child is not able to speak monosyllable or bisyllable word. Child turns toward the loud sound and he follows the moving object, means vision concern is less like. Also, mother is also complaining of tightening of upper limb and lower limb, more in the upper limb than the lower limb. Also, complaints of abnormal position of the right eye. There is excessive salivation. On inquiry, fisting of the hand till 5 to 6 months was there. There is a feeding difficulty. Child spits the feed. No history of constipation. No history suggestive of there is no history of neonatal jaundice. No history of convulsion. No history suggestive of dysmorphic facies or excessive vomiting. No history of excessive sleepiness or dry skin. No history of sibling death. No history of abortion in the mother. Immunization history. Child is immunized till booster 2 according to National Immunization Program. Dietary history. Child is taking 900 kilocalories with a deficit of 200 kilocalorie and 12 grams of protein with a deficit of 3 grams of protein. Family history, they belongs to lower socioeconomic status. On examination.
Okay, so what did we gather from the history? Who wants to start analyzing? Yeah.
Sir, from the history, we have seen that the main complaints for which the child is brought is that there is developmental delay in all the 4 domains present in this child, and along with the developmental delay, he also has certain sequelae or certain complications of the developmental delay, which he has also commented in the form of squint, in the form of feeding difficulties. Now, the history-wise, there is one point which is important, is that the history of delayed cry, and for which the child was shifted to the NICU and was treated with IV fluids. So that could probably, not surely, probably be the cause for the global developmental picture that this child may have. So to start with, there is a global developmental delay with sequelae, with the etiology probably being a history of delayed cry.
So there are many questions that arise. So first of all, let's take that cry bit first, then we'll come to the global developmental delay. So I think the history we got was that the cry was after 5 hours.
5 hours.
What does that mean to you?
Sir,
Anybody else before he? Yeah.
Cry after 5 hours. We want to know what about the activity and color and that type respiration, and what done in 5 hours, initial 5 hours.
Actually, mother is not giving that history because the mother was not with the child at that time, but the child is not fed that time, and after 5 hours also child is poor in feeding.
No, sir, I did not cry. That's not mean we want also enumerate the history in point of activity, colors, and respiration also. So we should to know that.
Sir, actually, there was one point which is mentioned that there are some factors which, according to the American Academy of Pediatrics, that a child is more prone towards a hypoxic damage. Like there are some points, like say if the fetal acidosis, the pH is less than 7, heart rate is less than 60, and delayed cry, the first cry is delayed more than 10 minutes in the first cry, then probably the child is more prone towards hypoxic damage. This is
No, that is correct. So what we need to, yeah.
The history of delay cry is not important. This is guidelines.
Hold it closer to your mouth.
History of delay cry is not important. History of spontaneous breathing movement is important. So I like to know about the history of prolonged labor or history of birth trauma is there. Suppose baby cried later on also, no problem, sir.
Okay. So I think to put it in proper perspective, saying that history of delayed cry is not important or cry is not important is not correct. What lessons we need to learn is cry is not the only thing to go by. That is the lesson to take home. And to your point, delayed cry as a point when observed by the doctor on duty. But when you are taking the history from a parent, and if the parent says cried or not cried, you will have to take it in perspective. So you will have to take the whole picture and decide. So your American Academy of Pediatrics criteria is when the doctor who is resuscitating on duty documents that the cry was so many minutes delayed, then it may have X prognostic significance. Okay. Now obviously here 5 hours nobody would wait, and he also said that no resuscitation was required. So which means that 5 hours cry is not, we are not giving the importance of the cry to whether the baby was asphyxiated or no, and no resuscitation was required. So that means the baby was deemed to have started breathing and heart rate was normal, etc., etc. Right? No resuscitation was required. Yeah. So we have discussed this many times that we want to establish a neonatal encephalopathy. That means the behavior of the baby to decide whether there was asphyxia or no. Okay. Now, what do you make out of the subsequent course? So the baby was dull apparently after 5 hours and was then taken for IV fluids and all. So what do you do with that?
I want to ask question whether baby's delivery is attended by any skilled person or any pediatrician. After that, I will also ask for whether baby is sick or not, whether baby is admitted in NICU as after delivery right now or after 5 hours. That duration also makes a lot of sense. That
delivered by trained person, and child taken to the NICU after 5 hours, and that time child is not great and he is not able to suck.
So see what happened during those 5 hours, the mother will not be able to tell us probably. But what do you make out of this? He is saying that the delivery was by a trained person and baby was shifted to NICU after 5 hours. So what do you make out of this?
Consequences of hypoglycemia is there.
Okay.
And thereafter decreased activity and shift to NICU and with the IV fluids.
Okay, you want to say?
the same thing. So the hypoglycemic cause could be there for the probably for the global developmental delay with this child.
So I suppose
Sir, initially for 5 hours baby was apparently alright. That means that the ischemic damage was not so severe. So it may be a moderate or
Can you tell me one thing which emerged in the history which will support this? He said no history of, and there's one thing which is very important which will support this.
So no need for resuscitation in this child.
And
History of convulsions.
no history of convulsion.
Very good. No history of seizures. So now if you expect this baby to have been badly hypoxic, then no seizures is a oddity.
I think to me this baby was just sleeping since birth. Okay, what was wrong with the baby? Baby did not need resuscitation. Baby did not need any intervention. So let me call it the baby was sleeping. Could the baby be sleeping at birth? So I want to know what were the maternal drugs given. Okay, was it an effect of a maternal drug that the baby just did not cry? Sleeping. The very fact that the baby did not need resuscitation means that the baby's fundamental system functions were normal, which means to me that the baby was sleeping. Let's call it just the baby was sleeping. Why could the baby be sleeping? In other words, was the baby sedated? Who would sedate the baby? Did the mother get anything intrapartum and therefore the baby had some effect? Or did the mother had some other issues like, is the mother alcoholic? Is the mother a smoker? There are many things that we need to know, because this story is not one of any birth injury. As you said that, it looks like that the baby was all right, but certainly looks sedated. So I would like to know details of how was the mother, what medication, was she on any medication? Imagine, suppose that she has been on an anticonvulsant. Okay, she's sedated, the baby is sedated, and wait for a while, the baby would get a seizure, if you like, after a withdrawal symptom. So I think to me it sounded like the baby was sedated, and I would like to know why the baby was sedated.
Can you suspect some reason why the mother could have been given some?
Mother have a history of hypertension during pregnancy, so she must be given some medications like magnesium sulfate.
Okay. So we have decided, yeah. Magnesium sulfate does not cause No. That does not cause sedation.
Doesn't cause sedation. You can get loppiness.
Sridhar, please take a mic.
I thought magnesium sulfate does not cause sedation. It is a CNS depressant in toxic doses. It's more of hypotonia and respiratory depression.
She could have been given a sedative as an adjunct to her antihypertensive treatment, so and that could have passed on to the baby, right? Okay. So now this
Rajesh,
was,
can I get some questions in now?
Of course.
So the first one was they objected to your social history. They said you didn't bring our friend Kupuswamy into the picture. So you must always talk about Kupuswamy when you're giving your social history, and that's a valid point, right? Second thing was somebody wanted to know that developmental delay be a part of developmental history, or should it be in the origin, duration, progress? Well, if your chief complaint is developmental delay, it comes in ODP, so that's the other thing. And the third point which was being raised was, can we say that this baby was depressed rather than sleeping? Instead of saying, as sir said, that this baby is sleeping, could we say that it was depressed?
Yeah, we can say he was depressed. Sir just was teaching that you have to differentiate from a effect of asphyxia and something else. So that sleeping obviously was not normal sleeping, because
actually the word depression means it's pathological. Okay, and I'm not ready to call this baby pathological at birth at all. This baby didn't need any resuscitation. If the baby was depressed pathologically, whatever the cause, well, the baby probably would have needed some resuscitation. So this was, to me, yes, you can use the word depression. Depression to an adult means awake and depressed. Okay, so that's not the depression we are talking about. And I think to me, therefore, was it the effect of a maternal drugs? You may call it depression. What is depression? Just lowering down of a consciousness, but it's not pathological. I'm sure this was not pathological because there was no intervention required. But if there was a pathological depression, well, what do you mean by that? Not only the cortical function, even the lower down brainstem function could be depressed, and the child would probably need hypoxia. So I think what is more important for me is that what happened after 5 hours? Okay, how was the baby behaving after 5 hours? Okay, if this baby was just sedated transiently because of any maternal effect, the baby would gradually wake up to be normal. Now the question is, how was the baby behaving at the end of 5 hours? Was the baby looking all right? Delayed milestone came later. There was no seizure at all. How was the baby between the hour 5 and maybe 2-3 months? By the time you realize the baby was delayed.
Sir, I think he said in the history that at 5 hours the baby was found to be not active and not feeding well, and so was shifted to NICU.
Sir, here one possibility might be more is birth asphyxia, because hypoglycemia can be one sequence of birth asphyxia, because baby moderate to severe birth asphyxia child can do the convulsion within 72 hours. So we cannot initially say it is convulsion or initially period. More possibly likely here will be birth asphyxia, can be basically as hypoglycemia.
No. You're mixing up issues. What we said by convulsion is, we said severity of birth asphyxia correlates with severity of symptoms. So if we are postulating that this baby did not cry for 5 hours due to birth asphyxia, then this baby should have had convulsions and many other things. That is what we meant initially. So that was about the convergence. Now, to your point, whether this baby had birth asphyxia, our strongest point is that a trained person was attending the delivery and did not feel the need to resuscitate the baby or do anything. So that is strongly against birth asphyxia.
When we talk of birth asphyxia, we only concentrate on the moment of delivery. But there has been a long period before the baby was born, and therefore we should not overlook the aspect of prenatal, before the baby was born, if there was been a prolonged labor and the baby is born, there has been an intrauterine, so to say, asphyxia, which will not manifest as birth, as delayed cry or something. The manifestations can occur up to 48 hours. So this baby would look, maybe he cried immediately after birth and later on was never so active. If maybe left like that, would have started manifesting with other manifestations. So up to 48 hours can be a presentation of a asphyxia which has occurred before the birth. The baby may have cried, and this particular mother was hypertensive, maybe some preeclamptic events may have happened, and therefore if there was a prolonged labor, then this baby had enough reason to have a significant prenatal asphyxia, the effects of which will show over a period of time. And then of course the other events may occur like hypoglycemia. This baby would have remained hypothermic also 5 hours. Also we will not overlook the fact that this particular delivery was attended by a trained person. Now trained person means a trained eye who will see, well, the baby is crying or baby is breathing, not crying. So everything is all right. But all other parameters may not have been so good as we want. The baby may have cried. The Apgar, if you and I were to see, maybe he would have been 6 and 7. The baby would have just slept on, and then when the baby was totally inactive, then the baby was transferred. So there must have been more than one event that must have occurred which ultimately resulted in a baby who was unresponsive 5 hours after birth.
The point is that such a baby would cry well at birth and thereafter would go down. What he says is the hypoxia occurred few minutes or hours before actual delivery, so the effect was already not much seen, but then the baby would cry, and thereafter when the baby wakes up you will say that the baby was not normal. Okay, what he's trying to say is that just because baby cried, it does not mean baby did not suffer from a birth asphyxia. That's the point. Here the baby didn't cry at all. That's a little worry to us, which means that the baby at birth itself was some way abnormal, to which I thought, could it be abnormal? Yes, but not abnormal because of its own suffering, because of some iatrogenic or some other factors. But that's what we will have to look at, yes. As far as hypoglycemia is concerned, there is no reason why a normal baby gets hypoglycemic in 5 hours, unless it's a diabetic mother or it's a preterm, IUGR, etc. If this, yes, so the point is that yes, now all that, if we agree that this delivery was attended, I imagine everything was looked after. So what is peculiar in this is why did the baby not cry for 5 hours and was sleeping?
What happened after the
Child kept in NICU after 5 hours of life. Their day of life 3, nasogastric tube feeding started, and discharge after 8 to 9 days of life. But after discharge also, child was not so active and not taking breastfeed adequately.
Was it a thyroid baby? Yeah. Not only hypothyroid, a thyroid. This baby comes out almost sleepy, does not cry, does not feed, remains lethargic, and now we have a thyroid baby, not even hypothyroid. Some good clinicians even examine for a thyroid clinically, whether thyroid is present or not. Not easy, I suppose. But yes, so we'll keep in mind one reason for such a baby could be the baby is severely hypothyroid or almost euthyroid. And I think that would be another way to discuss this.
Sir, there is no history of excessive sleepiness, dry skin or abnormal cry of the child.
Hypothyroids don't cry. No question of abnormal cry. They are lethargic. They are sleeping. But you could have added to say that was the meconium passed in time. A delayed passage of meconium might have supported, that it could have been just a hypothyroid, etc. So I'm just making another point that yes, sometimes a thyroid baby could exactly present as lethargic, not feeding, sepsis, etc. And you just have to put up a heart rate and you will find that, don't call it sepsis with a bradycardia. So you would know clearly with heart rate that the baby is.
What was the advice given at the time of discharge?
Actually, I did not ask.
And whether breastfeeding was started during the period of NICU stay or after that, whether they tried for that or...
They tried breastfeeding at the time of discharge, but the child was not taking well. Birth weight is 2.5 kg.
2.5 kg. What was the maturity of the child and what was the birth weight? So that it will define the future course of action intra-NICU period and thereafter.
Birth weight was 2.5 kg.
Okay. And the gestational age?
It full term.
So it was full term, relatively appropriate for age child.
Yeah.
Okay, that's fair. And then there was no significant intra-NICU event.
No.
I mean, there was no hypoglycemia, there was no sepsis, documented sepsis, suspected or proven sepsis. And on day 3 we started on feed, which was OGT or NGT. And then on what day he was put on the oral feed?
On day 6 or 7 started breastfeeding.
Fair. And he was doing well with the breastfeeding.
In the hospital he was sucking, but after discharging home, mother is complaining is not so good.
So there was a reasonable period of fair baby from from hospitalization day 5 to day 7 of day 5 to day 7. Total 12 days he was fair enough. Yes. You got my point. So the question is, what is been there which is ultimately leading to all these things? It was intrapartum or immediate postnatal event that we have to look at for the causation of this developmental delay.
Now we come to the second aspect. Who will analyze the developmental delay? Please speak in the mic. Please ask for the mic and speak in.
One thing I would like to know, how right we are about asking no history of dysmorphic faces.
Well, right or wrong, as in, I take your point, it has to be confirmed by examination, yes. But you can always ask the parent that did the baby look like every other baby or did the baby look different?
Agreed.
So to that extent, it is not a greatly wrong history.
Okay.
The point being made is, to each parent, his child is most beautiful on this planet. So they will never say that there is anything abnormal.
Yeah.
That's what he's trying to say, I think.
Yeah.
And also there is going to be a confirmation later on. We are not going to depend upon what the mother said, and it will unnecessarily introduce
exactly
unnecessarily
thought
in our mind.
That may invite trouble to us in the examination. Some examiner may be tricky, so they would like to know what are the features that you would like to know in that, and what is exactly you are looking in for that.
I think you could have at the birth said that on direct questioning, the mother does not find the baby to be anyway abnormal.
That's fair. That's
okay.
Fair.
That's also on direct questioning.
Yes.
Mother is not coming forward. That you may mention, but I agree to some extent. Dysmorphism is not easy to make out
in history.
So he's making a point that an examiner might push you down on that, exactly. Or at least question, and you will have to have a defense ready.
True.
To say that, no, I asked a direct question whether you find the baby abnormal, and she said, no, the baby doesn't look to be abnormal. Therefore, I said, no dysmorphism. So you can get away with a question that, yes.
Thank you.
So now can you analyze the developmental delay and tell us what it means to you?
Gross motor wise, child achieved head holding at 6 to 7 months and sit with support at 18 months. sit without support at 2 years, but he is not able to stand with support. So his developmental age is around 9 to 10 months. So development quotient is around 35 to 38%. Fine motor wise, child holds object momentarily when given at 8 months and try to reach object in the prone position in 18 months. Mouthing also develop at 18 months and ulnar grasp at 2 years and not achieved pincer grasp. So it's also developmental age for the fine motor is also around 7 to 8 months. So development quotient is around 35% around.
How did you achieve that? 7 to 8 months, and then what did you divide it by?
Will you just explain how did you calculate the 35?
Developmental age divided by chronological age into 100.
So what was the development? At what age is the...
Whatever milestones you mentioned, when was the last mentioned milestone achieved? Today's, if you are taking today's age into consideration and dividing by 2 years and 4 months, it is not correct.
Okay.
At what age the child achieved a milestone and at what age it was supposed to be achieved? If the milestone was supposed to be achieved at 8 months, which the baby achieved at, let us say, 18 months, but thereafter the baby has not achieved anything from 18 months to 2 years and 4 months, then you don't divide 8 months by 2 years and 4 months. You divide 8 months by 18 months because that milestone was achieved at 18 months. Okay, so that is why I wanted to ask you, how did you calculate that? So if you have divided by 2 years and 4 months, then that is not right. A given milestone, at what age it was supposed to be achieved and what age it was achieved. Suppose this particular child doesn't achieve anything till 5 years. Are you going to divide 8 months by 5 years? No.
If a child achieves a milestone of 18 months, like 8 months milestones at 18 months, then suppose he is after 8 months, the milestones which he achieved is much later. Then it will be like a dynamic development question.
Yeah, so then what you have to write down whatever milestone 8 upon 18 and then quote the milestone, next milestone 10 upon 35. Okay, because every milestone is not going to be achieved at the same speed. Some milestones which are easy to achieve will be achieved early. Some milestones which will be achieved little later. So for head control, let us say, it was 3 upon 8 or whatever. For sitting, it was 8 upon 18. For standing, it was, let us say, 10 upon 12 months upon 10. And for walking, it's not achieved yet. Okay, so this is going to be the graph, and therefore every milestone has to be first decided which milestone, and then age at which it was achieved and age at which it was supposed to be achieved. So that developmental quotient is for that milestone. When you draw a graph of different milestones achieved, suppose you are talking about hair control and it was 8 upon, let us say, when was the hair control achieved?
Head control achieved at 6 months.
6 months. So what was supposed to be achieved at 3 was achieved at 6 months. So that was 50%. Okay. So it was 50%. Then the next milestone was?
Sit with support at 18 months.
So what was supposed to be achieved at 8 months was achieved at 18 months. So 8 upon 18.
सर ते खाली केलेले मंथ्स आणि तिकडे पर्सेंटेज केलेले.
What we want to say, it started like this, then it went down like this, then this is not static, this is deteriorating. If he started with 50 and remained 50, then he is static. And if he started with 50 and slowly going up, then he is improving. This is true for every milestone, every domain. You draw a graph like this for a gross motor, a fine motor, social, cognitive and language. And then you say, how is the global developmental delay? What do you talk about? DQ at 3 months, 6 months, 12 months, 12. You plot a graph of a DQ and not just the milestone. And if the DQ is worsening over time, it's a worsening disease. Otherwise, in a static disease, the DQ remains nearly the same. There could be a small improvement by some intervention. And I think that is what you need to do then. You're all clear, I'm sure, that when you talk about that, you have to draw a DQ curve, whatever the milestones you ask, and what is DQ, at what age it should have come, instead at what delayed age it occurred. That's the DQ. So like we said that the head holding was to be at 3 months but occurred at 6 months, so then the DQ is 50%. And in which case, if standing was expected at 1 year, normally standing at 1 year, in a child with DQ 50%, it's expected at 2 years. But suppose it happened at 3 years, then the DQ is going down. I'm sure we are very clear about it. This is what you not to plan.
And for different skills, you require different sort of potentials. For example, the potential that may be required for hair control is different than potential that is required for standing and walking, because many other CNS functions are required. And therefore, it may show that initial DQ was 50, but later on for other milestone it was not so, and this child of 2 years and 4 months is not able to sit without support. That means he is not able to sit without support, or he is able to sit with. So sitting without support is at, let us say, 8 months, which he has achieved at 24 months.
Sitting without support is achieved at 2 years.
So 8 upon 24. So as the time is advancing, instead of catching up with milestones, this particular child is not catching up with milestones. The conclusion is maybe this particular child may not walk or may walk very late. Okay, but if this same thing happens for a developmental other developmental domains, then you are more worried there. Here you may not call suddenly a motor regression, but if these milestones are not being achieved for a long time, then you don't know how far this child is going to achieve. There is going to be some plateau at one time or the other, because development will not continue indefinitely. At a particular point there will be a plateau, and then that will be the final achievement at that. That will come at 4 years, 5 years or so. Thereafter there may not be much achievement. There may be some skill, social skill, etc. which are achieved, but real development achievement may not take place, because the brain growth, let us say, is up to 5 years or so. So you draw the DQ in each and for every milestone, so we know how it has progressed. Then you draw this for every domain of milestone, that means gross motor, fine motor, then speech, language and cognitive, and you know where is he delayed the most. If the child is delayed in physical or gross motor milestone to an extent of X, then the delay in intellectual and milestone is expected to be 2X or something more than X. Unless this particular child has cerebral palsy and a retained intellectual function, in which case his gross motor will be out of proportionately delayed, but at 2 years he may have significant cognitive milestone. He may speak, he may recognize strangers, he may do things which he is not expected to do, going by the gross motor milestone. So this is how we should analyze. So there is a delay and there is a differential delay. Okay, if a differential is there, if gross motor is too much delayed, you are expecting a motor handicap. If speech is delayed, then you are thinking of hearing or maybe autism or something. If fine motor is delayed, you are worried whether there are fine motor skills achieved or there is a problem with vision. So by tracing, you can almost suspect what is likely to be the problem, and this is how we will analyze the milestones.
Only one addition is that don't forget that worsening malnutrition would delay the motor milestones. So you'll get a wrong idea that motor milestones are not catching up. So also give a credence to what's happening. For example, if the child is growing very well and has rickets, he may be again a little motor delayed. So when you have a motor delay occurring, that means the DQ is going down. You are concerned whether it's a progressive disorder, that means a degenerative disorder, or on all other domains the child is doing well, is it only a locomotor problem? So keep that in mind. Many children would be malnourished and would not able to pick up a next milestone. Yeah.
So I think
Rajesh, there is a comment. There are few comments because this development is a very difficult issue for most exams. So first comment is that these graphs which you want us to do is impossible to do in the exams. What are your comments on that? What should we do? We have limited amount of time.
No,
you
the
don't have to
concept-
draw the graph. This was just to explain. You can just write down 3 upon 18 is, let us say, less than 50 or 30%. 50 motor development, gross motor, sitting, 50%. 70%. Standing, 30%. You don't have to draw the graph, but the figures are there. If you know that sitting is at 3 months, and has been, 8 months, and has not been achieved or achieved at 18 months, it doesn't take any time to say that 8 upon 18 is the quotient of this.
Sir, I think the point is,
in an exam, if you have practiced it so much, it doesn't take time at all. As an examiner, I know you are fumbling. This is the first time you are doing it. Okay, you are supposed to be doing developmental examination so often in every child. What is the problem? Here we are discussing to explain. There, in a fraction of a second, you know whether the DQ is going down or not. Okay,
I think
it only tells the examiner that, oh, you have been practicing it so often. So don't say that it will take time. If it takes time, it may take another 6 months.
So that's a very scary statement. I think the basic purpose of taking this developmental history is to come to the conclusion what Dr. Khare has just told us, whether it's a global delay, whether it's a differential delay, and which differential tells you what is the type of defect you are anticipating. We must not forget the trees for the forest, and we must understand why we are doing it. That's most important.
And whether it is progressive or static.
Absolutely. So there was a question asked whether there is a loss of any achieved milestone. Now that would be for looking for regression. Do you have any history of loss of any achieved?
No.
So no. So we have ruled out that. Yeah.
And when there is a loss of an achieved motor milestone, we have to be careful whether complications like contractures etc. are setting in, and that is causing a loss of a achieved motor milestone, or other malnutrition, so many other things. Okay, so we'll examine the child now. Come. बच्चे को देखो.
Meanwhile, as this child is being brought up, who will tell me how do we sort out all that we discussed on examination? Will examination tell me whether this was a CP or whether this was prenatal issue or whatever it is? Because unless I have an idea what I am looking for, what am I examining for? Whatever I see, no. I must know what I want to say. So who will? Yes, please go ahead.
Head circumference, how will it help us? Your mic is not working, I think. Take this.
If the head circumference is decreased substantially, that means the insult has taken antenatally. And if the head circumference is normal or near normal, then insult has been occurred later in life.
So on examination,
Even scissoring of lower limb will tell us that it is a birth asphyxia, maybe periventricular lesion may lead to the lower limb.
so certain facial,
You can just leave the mother and the child alone, and you can just assess the child and how the mother is taking care of the child. Like if you are expecting that the child, now if looking at the child, I can see that he is sitting without support. If I can ask the mother while she was lifting the baby up, I can observe for the scissoring of the lower extremities. If there is a slanting forehead that I can see, I know it is microcephaly, and if there is any obvious, I can see whether it is microcephaly. I can just observe the child if he is able to move over the bed, or just leave him on the ground and see what disability he has, whether he can crawl or whether at least he can stand on, just by observing the child without.
What I wanted you to say is that there is a CP. That's
Sir,
what we are talking about. What is CP? Change in the tone and posture. I would have first look at his tone and posture, and of course look at the head circumference. That will tell me how early the damage has occurred. Two things would come in. Then of course the rest of the many things would come in. But if there is no change in tone and posture, then probably we are not talking about CP at all. And if there is no small head circumference, we are probably not talking about a CP. two important things that I must have, by and large, if I'm going to call this as a CP.
And also, if I get a CP of a particular type, that means cerebral diplegia in this particular child, then I would give importance to asphyxia, because associated with asphyxia, that is the common type of cerebral palsy, because we have periventricular leukomalacia and the innervation of the lower limb suffers most. And therefore, if I have a CP, especially with lower limb affection, then I will give credence to there must have been some degree of fetal or neonatal asphyxia. On the other hand, there is a big history, but the head circumference is not significantly affected. A badly asphyxiated baby must have a relatively small head. If the head is relatively big, then I would think of other factors. For example, a subtle hypoglycemia may not give rise to a considerable microcephaly, though prolonged hypoglycemia will, but it may give rise to a relative to take it a little further, a mild hypoglycemia in a premature baby which even has gone undiagnosed. This particular baby will behave normally, but when he's 6, 7, 8 years, he may start getting occipital epilepsy. Okay, he may have mild cognitive development, he may do well in school and college, but he may find difficult to reason out certain things. These are subtle things that may occur, which are explainable on hypoglycemia, but will not be explainable on the basis of significant asphyxia. So if the head is reasonably alright, a very bad asphyxia is less likely. Often strabismus, bilateral strabismus we see with cerebral palsy. So if I have a child with bilateral strabismus, especially the convergent squint, that will favor some degree of spasticity, and therefore spasticity which is related to the asphyxia.
Which CP doesn't have a seizure? And which CPs mostly have a seizure?
Hemiplegic.
He has had no seizure. So then if I expect a CP, I know which CP I am expecting.
Hemiplegic CP.
So also correlate that. Okay.
Dyskinetic CP.
Extrapyramidal bilirubin toxicity. Yes.
So would anyone like to come and talk about this baby on inspection and tell us what all we can get on inspection itself?
Child is comfortable, he is interacting with mother well. He is in sitting position, but sometimes he is not balancing. He is playing with the toys. That means he is interested in surrounding also. On inspection, child is well looking right now. Child is not sick.
Yeah. Go on. No, in a CNS case, there are lots of things you can do on inspection, right? So in a CNS case, right from the head size, which we were saying is so important. So what is your general impression of the head size? Then sir was, yeah.
Head is a microcephaly. Child is interested around surrounding.
Which is not wrong.
Head is microcephaly, child is interested around surrounding and not looking like a spasticity and a hypertonic, and playful and
abnormal eye movements also. Some degree of squint is seen. Left side. Drooling of saliva.
So now without touching him, go near him and do some maneuvers and show us some more observation. Don't touch him so far, but you can do some maneuvers and make him do some things. You got my question? Go near him, don't touch him, and do some maneuvers to get him move his hand, move his feet, move his face. Okay.
Start a reflex.
You come on this side. Come on this side. Come. We are not untouchables. Yeah.
Startle reflex.
some possibility of movement on the left side. He is moving more on the right upper limb than the left. So, examination will be confirmed, but on inspection it seems like there is some possibility on the left upper limb and lower limb. We'll confirm the examination part.
He is following the object.
He will go on the other side and go on the left and cross.
He is having some incoordination. He is not properly reaching to the object. There may be some degree of dystonia also.
Sir, Dr. Ambedkar sir, they want to know which are the CPs which don't have a seizure. They didn't get the answer, so they are asking you to tell us again.
Extrapyramidal CP for the connectorous basal ganglia.
Okay.
Least common in dyskinetic CP followed by hemiplegic CP, most common in quadriplegic CP.
So what have you got so far on inspection? What things that you have got? So can you think that all the cranial nerves are normal, or you think there is some problem with one of the cranial nerves?
Exactly. There is some degree of squint.
So
there
now,
may be some.
So because you observe a squint, now next you need to decide whether this is paralytic or non-paralytic. So that's what sir was asking, that without touching him, can you do something to check whether it's paralytic or non-paralytic?
Covered test, uncovered test also. Or
Just make him follow some object, no?
Yeah.
I mean, show him some light or something and see whether you can. Anybody has a torch?
Side पे चलेगा वैसे वो दूसरा साइड के अंदर लेगा.
Which is moving the neck.
No. So, see, sir has said that when you look at the eye movement, you have to steady the head. So, you have to see that the head doesn't move. Now, ask the mother to do it. So, that means there is no paralytic squint. So, there is none of the cranial nerve involved there. Now, you are drooling. So, do you think that drooling is due to a cranial nerve palsy?
It may be spastic pseudobulbar palsy.
Okay, so that you will have to check. Okay. What else? Do you think power is normal? Grossly in all four limbs?
Actually, he is moving all four. He is moving upper limbs well. He is touching to object. I think power must be more than 4. But I have to examine and I have to confirm my findings.
And looking at the posture of the limbs, do you think there is a tone abnormality?
Tone abnormality may be there because he is not properly sitting. In sitting position, he has to extend his lower limbs.
Okay.
Tone must be increased.
Okay. Maybe. No, but at the same time, there are no typical increased tone postures that are visible, So that is the other thing. Okay. So now you want to actually examine and confirm your findings? Come. Yeah.
Please take a mic.
Hearing.
Yeah. So what about hearing? You tell me.
Distractibility. Suddenly make some sound from behind, and the child will look at their.
Speak in the mic.
Suddenly make one sound from. We will make sound from behind and see the turning of the head towards the sound.
What sound?
Any clapping or any bailing, any available to you.
Ideally, the sound should be somewhere in the frequency of normal hearing, and some of the sounds is if you have a metal spoon, then that sound also simulates the normal our decibel that we have. Simple clapping is good, but another good sound that we can make is this crumpling of the paper. appears, I will have to do it
Sir, hold,
again.
sir, mic.
Hello.
Sir, hold the mic close.
Hello. How are you? Yeah, when I'm engaging his attention and making noise, unless he's looking at this doctor, I think he has some hearing to the extent that I can examine clinically. You can also ask the mother, आप मागे उभं राहून जर हळू बोलला तर बघतो का, हळू हाक मारली तर हिंदी समझते हैं? हिंदी आप पीछे अगर उसके एकदम धीरे से पुकारे उसके नाम के तो देखता है.
Kare sir, your comment on clapping and making loud noises.
No, not loud, not very loud.
Because that's what most people go with the impression that that's the way to look for hearing.
Or, a metal vessel and a spoon.
Yeah, but behind the child, not in front.
Behind the child. And it's a very loud noise.
Mic, sir, mic.
That the child gets startled with a fataka does not mean the child is able to hear properly. As Dr. Rajesh has put it, any deaf child can perceive the noise of a big fataka, and a very bright light any child with impaired vision can see. So, you have to have a noise and voice which the child should be able to appreciate the hearing range, decibel wise.
Sir, whistle in the mic.
In the developmental kit, the Denver developmental kit, there is a small bell. Okay, that has again the adequate frequency, appropriate frequency. That small bell, if you have, that ghanta which you keep in puja, that is again something which is worth keeping.
On examination, I will start with the CNS examination. A child is comfortable in mother's lap. He is well interacting with the mother. He is also interacting with the examiner also. He is cooing right now. He is not speaking any words. I have to ask to mother for this. Then after that, I will also comment on posture and nutrition of the child. He looks averagely nourished. I want to confirm it after by anthropometric measurement. Then after that, I will go for cranial nerve examination. In cranial nerve examination, second nerve, optic nerve, I have to look for right reflexes, indirect light reflexes.
No, I think we discussed that you have to be a little quick about all this. So now I think he is getting irritable. So quickly do his motor examination to confirm whether he has spasticity, any tone abnormalities and...
Rajesh, while she is doing that, can you tell us how the size of the head decides whether it's an antenatal insult or postnatal? What is the logic behind that?
No. So I think what the point we were making is that if there is any significant insult around birth, then it does affect the growth of the brain, so that subsequently you will have a small head. So in fact, if we diagnose CP in any child and if the head circumference is normal, then it's you have to revisit your diagnosis. So that is the way it affects.
Rajesh, when you said revisit your diagnosis means you were wrong the first time. You're saying it politely.
You have to check. There are some situations where think conditions will be closely mimicking CP, and there would be some genetic syndromes, etc.
Well, I can put like this. Suppose I have a child who has achieved expected head circumference at 6 months, and we have that head circumference 6 months at 12 months of age. So probably this insult has occurred after 6 months of age. Till 6 months of age, he was fairly well. This is the way I can interpret.
No. That is not fully correct, sir. Because it is not that the head circumference will stop completely growing after an insult. The speed will slow down.
True.
So if you have a 12-month-old child whose head circumference today is that of a 6-month-old, then insult has not occurred at 6 months, because suppose insult occurred at 4 months, then 4 to 6 is not zero growth but slower growth. So that
means the rate of growth is equally.
For example, in this child, if his head circumference is 40 centimeters, which correspond to let us 3 or 4 months, that doesn't mean that he was normal up to 4 months. Insult has occurred after 4 months, and after that the head growth has stopped altogether. If you draw the graph, it will be always on the lower side, less than third percentile, and at a particular time the head is going to stop growing. Okay, so that is why it may not be. It only tells you that the insult has occurred much earlier in life.
So other way around, the serial head circumference would be more important than one point of time.
Yes, and if you have the records.
Right, the record. Great.
That's the more bigger
Great.
problem. You
Great.
don't have records. Yeah.
So the thing is, intranatally, head circumference is the one which grows the fastest, and that's why when even right now and after birth it slows down compared to the intranatal age. That's why if the birth head circumference is very low, that's the reason why we say most probably the insult has occurred antenatally and not postnatally.
Yes, absolutely. The head circumference is 31 or something like that. And if there was a record at head 31, circumference is too small a circumference, even if there was some degree of perinatal insult.
So this is the point. There's, see, antenatal problem, head circumference smaller than even normal. At birth problem, to begin with near normal head, which subsequently didn't grow. So that subtle difference you have to make. So if you have 31, 32, that means he was not normal even at birth. And that is the clue which gives you that it was antenatal.
Rajesh, there is another question which says malnutrition can cause microcephaly. I would suggest that microcephaly would be rare in a child with malnutrition because the brain is spared. So it really doesn't come into
unless the word malnutrition is extended to intrauterine symmetrical IUGR, then malnutrition can cause microcephaly.
On examination, sir, in upper limb tone is increased. On inspection, child is moving upper limb well, but he has some degree of dystonia. That's why tone is variable. And on palpation, muscle feel, it is also spastic. Then whenever I go sit manually, that time also child couldn't sit properly. He used to stand up while I am pulling to it. Traction response is not proper. And also child is not child is having scissoring. He is not sleeping through hand. And tone is, my interpretation is, he is hypertonic. Hypertonic.
Hypertonic.
Spastic.
Rajesh, if somebody speaks without the mic, you repeat.
Will you demonstrate the clasp knife spasticity?
Yeah. For spasticity, I have to go fast. For spasticity, I have to go for passive movement fast. I will get a catch. I am getting catch over there.
Actually, we all had seen the catch that she showed. Okay, when she was examining, there was definitely a clasp knife. So this child has got. Plus, there is some dystonia as well.
There is definitely
in a CB, there would be all tones. Yeah. In fact, there could be some hypertonic, some increased tone rigidity, dystonic, all combinations. So it's not.
So variation of tone is there because of dystonia.
Yeah, and she made
has done what is known
point.
as the 180-degree test. You have, no?
Yeah.
So the question is, what is the age limit for that?
And
what are the components? Tell us so that we all learn.
In pull to sit, first we can see whether child is holding neck completely or partial neck holding is there, making him pull to sit. That time we can also observe for the traction response also, whether traction response is normal or not. And if child is hypotonic, we won't get the traction response in that place. Then after that, we can make a child to sit, and we'll see whether back is straight or whether child is falling backwards in spasticity. Then after that, I will also examine the child by axillary suspension. In hypotonia, we'll get slipping through child. Then I will also go for horizontal suspension. Whether he maintains the flexion or not, I have to look for. And in a prone position, whether child is maintaining the position or not. And I want to also go for the primitive reflexes, which I can examine up till 6 to 8 years also, if child is suspecting like cerebral palsy.
And it depends on how strong you are.
Yes.
Would you look at the neonate, would you look at the postural reflexes in this child? So at up to what age you look after postural reflexes? What reflexes do you look at?
If child is not walking according to the history, that make me sense that child has some balance and posture disorder. That time I want to examine the child whatever the age of the patient. I think there is not age bound. That
I wanted you to say whether are you going to do a Landos on this child? Are you going to do a parachute in this child?
Yes, very much so.
So tell me at what age you do what and what is your interpretation, because if the child is quite delayed, don't forget to do these reflexes also. If he was very much delayed, I would have even done an ATNR or an STNR, all that, because that is another way to see how far has the development gone, and therefore just tell us something about the reflexes.
Primitive reflexes in this child we can also see for the grass reflexes, rooting reflexes, sucking reflexes, then labyrinthine reflexes, tonic neck, and ATNR also. If child is not turning to opposite side, if child is not crawling, I have to also look for the STNR also, and for whether this child is not walking, for postural reflexes also, land use and parachute.
All that I wanted you to say that spinal reflex, brainstem reflex, brain reflex, and that's the way it is. And therefore you start with a spinal reflex which is just a flexion and extension of a neonate. You flex and he will not allow you to extend nor flex. Then you come the brainstem reflexes, Morrow's grasp, etc. Then you come to a midbrain reflexes, that's your ATNR, STNR, and then you come to a Landos and the parachute. So I think in that order, you need to look at how low the child is. You need to do those reflexes also, right?
You would have seen the adductor catch also in this particular child for spasticity. Sir, as you said, parachute is very important. It comes at 9 months. So, the later you have the reflexes, better is the conclusion. Something which disappears at 3 months, something which appears at 9 months and persists throughout the life. So you can draw a little better conclusion. Plus asymmetric parachute reflex tells you that one side is affected than the other. So parachute reflex is another very important reflex.
Sir, actually there is some controversial point. Some examiner doesn't like to go for parachute reflexes. In that situation, what we should do?
Then you should first tell that parachute reflex, I would interpret like this. Sir, should I do it, demonstrate it, or it is alright if I have said it?
There is a prognostic significance also to parachute reflex, and in fact in this child it is just about borderline. So let me first ask you, if you are asked whether this child will walk, what is your answer? Will this child ever walk?
If child started walking before the age of 2 years, just standing with the support also, that time we can...
We have to project, we have to predict, will he walk? If he is already walking, then where is the prediction?
He may not walk if up to 2 years he doesn't achieve any.
2 years, what should he achieve?
Sitting with support.
So if a child sits up to before 2 years, then he is likely to walk. If a child does not sit till 4 years, then this child will never walk. Okay? So parachute again, a child who has not achieved parachute will never walk. So in this age, that is just about, you have just said that started sitting at about 2 years. So for prediction, this is probably a child where you would do parachute if you want to prognosticate.
Shall I attempt it? Shall I attempt a parachute reflex? I'll talk to the mother. मैं जरा उसको लेऊं, थोड़ा सा उसको मैं पैर ऊपर करूंगा तो चलेगा? First I will do ventral suspension. It's not very stern. Yes. Was it there? I couldn't observe it. Did he fling his hand outside like that? Not very good. So parachute reflex has still not occurred. Also one important point which you made, his tone is variable. Sometimes I find that it is spastic and sometimes I find it is not spastic, which is a hallmark of dystonic CPs. The tone is variable. Sometimes when you see the reflexes and tone, you may find as spastic or increased tone. When you show to the examiner, you may not find it spastic. And then you may get confused. Though, if there is a variable tone is a hallmark of dystonic CP, while with spastic CP, the tone will always be the same.
So now, can you summarize how will you construct your diagnosis?
Age. 2 months male child. Came with the complaints of delayed milestone in all 4 domains without any significant complication, with involvement of the left side 6th nerve palsy and squint, abnormal deviation.
But you said that the movements are normal.
Actually, sir, sometime I am getting.
But do you get a paralytic squint in CP?
No paralytic squint.
Is there a raised ICT in this child? Why 6th nerve palsy? So how do you now defend your 6th nerve palsy? It's fine. You thought the 6th nerve palsy is there. It doesn't matter. You defend now. Who will defend for her a 6th nerve palsy? Isolated 6th nerve palsy. Okay, I would have called a raised ICT.
In Karnik Terrace, we get sometimes 6th nerve palsy.
The point is that isolated 6th nerve palsy in CP is not common. If there was a malformation to begin with, 6th and 7th are often together. Okay, to that extent we need to be very clear whether it's a paralytic or not. And if I'm doubtful in exam, then I would rather see it closely and say, probably this is not paralytic. That would be a safer bet. But if you are asked to find out, then you could have said, this could have been unrelated, this could have been any other event, it could have been a viral infection, it could have been anti-ron cell disease affecting 6th nerve. There are many reasons for a 6th nerve palsy, not that it cannot occur, but generally that would not be. So that would have been
with some degree of malnutrition also, and without any complication like bed sores, any.
So actually, you should first focus on your chief complaints and your chief findings. So 2-year-old has come with
delayed milestone in all 4 domains,
and in that we have to answer in questions which Khare sir said.
DQ.
Is it global delay or
global
differential delay, and is it progressive or static? Those 2 questions you have to
It is static encephalopathy and global developmental delay is there.
Okay, and then the next question is, what is the cause? So is it
Mostly
prenatal, perinatal, postnatal?
Probably being perinatal etiology.
Yeah, but it's not an encephalopathy. You said it was a static encephalopathy. Right now there is no encephalopathy. I am talking here.
Yes.
So
patient is achieving milestones day by day, then it is a non-progressive static encephalopathy.
Okay, so can you, Rajesh, anthropometry, I think we missed that.
Weight of the child is 10.6 kg, which is between -2 and -1 standard deviation. Length is 85.5 cm, which is between -2 and -1 standard deviation. Weight for length is between -2 and -1 standard deviation. Head circumference is 45.5 cm. It is less than -2 standard deviation. Mid upper arm circumference is 13 cm.
So interpret.
Child is not having malnutrition but has a microcephaly. Between -3 and -2 is a moderate. Between -2 and -1.
Sorry, what is the controversy? I didn't get it.
Actually, I am asking for what is the degree of malnutrition in this child.
What is?
Degree of malnutrition. It is moderate or mild degree?
Mild. There is a severe or it is a moderate?
According to WHO, there will be only moderate and severe.
So it's not a moderate. And there is a microcephaly.
Yeah, because it's more than 2 standard
Less than
deviation.
minus 2 standard deviation.
So particularly in this child, we should go for the Kanavati index and like that. If child is Kanavati index and like that, because we couldn't interpret with WHO classification. In that time, we should go for welcome, trust, and other parameters also.
For,
is it necessary
for malnutrition, I
Yes,
would
sir?
say that this particular child who is 2 years and 4 months has a length of 85 centimeters. So his height or length age is 1 year and 6 months, because at 75 centimeters at 1 year, 89 centimeters at 2 years. So he's grown lengthwise like 1 year and 6 months old child. For a 1 year 6 month old child, a weight of 10 kg is slightly on the lower side, but not very much low. And how much role of hereditary factors is there in his small height is also, we saw the mother is not very tall, maybe the father is not very tall. And if you are plotted in on the graph and he is coming to say 5th percentile and 10th percentile, and I had the previous length also, even if I have 2 legs and he is following the curve, I would say that he is probably genetically small. Maybe nutrition or the neurodevelopment is also important for physical growth. May have affected it to a small extent, but not to call it a malnourished child. And his weight for his length is relatively all right.
If the child has global developmental delay, but there is some dissociation between a few domains. All are delayed, but some are delayed more. Do we call this dissociation or is global developmental delay?
It is global developmental delay with some differential delay. The developmental delay in cognitive functions is much more than developmental delay in motor function. Or developmental delay is not so much in motor function and adaptive function, but in speech it is too much. Or the developmental delay in cognitive function and adaptive function is mild, but developmental delay in gross motor is too much, telling us thereby that there may be a neuromotor factor or a nutritional factor. So if there is something like that, it may be. But if it's more or less the same thing, now let us say his achievements are something like 8 to 9 months in all fields of development, then he has more or less the same degree of development in all fields of development. One small comment, that when you know the milestones, please try to analyze the milestones in such a way that some milestones which are independent of the motor function but only tell you the cognitive function are important. For example, laughing, according to Illingworth, is a milestone which tells you about cortical function. A normal child laughs at around 4 months. Parents say my child is laughing at a newborn baby. What they mean is smiling. So laughing comes around 4 months, but peekaboo comes around 8 months. Now peekaboo does not require any power or gross motor development milestone. And if a child is enjoying peekaboo at 8 months, I think his cognitive development is reasonably good. If he can crawl and if he comes up to the edge and just looks forward but doesn't cross that perception of death comes around 10 months. So if he has achieved that, then so when we go through the milestones, let us try and sort out those milestones which are going to be independent. For example, if this child is doing household mimicry and he's not so ambulant, but somebody is brooming and he starts doing that or imitating, that comes around 15 months. So you know that he has reasonable cognitive function, and therefore cognitive function becomes difficult to recognize in a child who has other handicaps. So let us isolate those milestones which are relatively independent of other functions and only reflect cortical function.
If a baby is laughing at less than 4 months, it may also be a gelastic seizure.
Of course, that like a seizure comes suddenly and stops suddenly. So he suddenly loves and then doesn't love. So it's a seizure, paroxysmal event. Now, what about nutrition? Say this child is not malnourished. Don't call him malnourished because he's below standard deviation. No, his weight for height is nearly normal, and I think try to also correlate clinical signs of malnutrition. Is he having a loss of subcutaneous fat anywhere? Is he having a small muscle mass? No. So don't call him a malnutrition. It's important in a CP whether he's malnourished or not, because one of the management is also nutritional management. And this child I don't think is a malnourished at all. So tell us, what investigation would you do and how will you manage?
Sir, take the mic. Sir, I have another
laughing
question.
is on stimulation. You tickle the child and they suddenly start laughing. By gelastic seizure comes suddenly, this is unprovoked.
Sir, one more question. The question is, how can we find out the cause of insult, whether it's perinatal or postnatal in a CP? What will tell us when the insult has occurred?
If the perinatal and postnatal history is absolutely normal, then I would think of a prenatal cause. If the the head circumference is too small, then I would say the perinatal insult has been really in the form of intrauterine infection or something.
For example, see in this case, the head circumference is 45 for a 2-year-old 4 months. So this is what Khare sir made a point earlier, that this is not prenatal, because if it was prenatal, he would not be even 34 at birth. That couldn't have reached 45 in this much time. So therefore, this is small for age, but not prenatal, and therefore this is perinatal. So this is the way to differentiate.
And crying also has to be taken with lot of, did not cry immediately after birth, has lot of other things to be answered. Some babies delayed cry. For example, Down syndrome babies are often known to have a little delayed cry, but their developmental delay is not due to delayed cry, it is related to Down syndrome. So, and what is more important is what is the subsequent course after the birth. If he didn't cry, but at 4 hours he sucked very vigorously and there was all right. There was no neonatal encephalopathy at all. So subsequent
other point which I just wanted to second Amdekar sir's point. See, -1 to -2 you said standard deviations. On your growth chart, +2 to -2 standard deviation is normal. So therefore there is no question of. So we tend to call it minus and then we jump to the conclusion it's malnutrition.
All minus is wrong.
That minus ka concept we have to be minus up to -2 is normal in all the measurements.
It may be worthwhile saying that
Except
height
in the
percentile is 30th percentile, weight percent is 30th percentile, so it gives you that impression that it is all that, not minus as you think it is.
Correct. So means minus the graph is 15th and 37th percentile. Those are the two graphs for -1 and -.
Rajesh, don't sit. There is one more question. People are very concerned about how to take length in a child with contractures. What do we do? For the exam they are worried. How do I take a length in a child with contractures?
True limb length and apparent limb length should be taken if contractures are fixed. If contractures are dynamic, that time we can take total total length or total height of the child as per the age. And that time.
Say that again slowly.
We should, if patient is having fixed contracture, that time we should go for true limb length and apparent limb length. Apparent limb length is taken since pubic tubercle to the heel of the child, and true length is taken from ASIS to middle malleolus. And that time we can comment if distance.
Then you add it to the upper segment. Is that what you are saying? I want to take the length of the child so that I can plot him on a chart. He's got contractures, so his lower limb is shorter, looks shorter. So what length do I take? I think it's a very valid question.
I think we'll have to take the length physically, going along the surface of the body. You start at a fixed point, let us say anterior, and take along right up to the heel. You may have to turn the tape as it turns, because that is perhaps the true length.
I think the most important part of every measurement or examination is the interpretation. Why are you worried about that? You have not asked me which tape are you using. Okay, I need to interpret. Now, large part of the contractures that occur, as she rightly said, if they are dynamic, I can really take the reasonably correct height. If they are not dynamic and static, I would certainly miss some part of the height. Question is, how would that come in the way of my diagnosis, prognosis, management? None at all. So, for that purpose, I would say that, can I take the length of each bone and construct? Yes, but that's a futile exercise.
Sir,
okay, because it does not tell me any interpretation.
only to put a child on centile charts
Yes.
are there.
I mean, if somebody wants to know theoretically, yes, I will have each bone, a femur and tibia and the lower bones measured. What do I do by that? And therefore, I feel that, yes, you can.
I think it's a similar situation to a nephrotic with edema whose weight is spurious, but we still plot that weight on the growth chart. So we say that he has got edema and we don't know what is the contribution. So it's better to just say that we don't know the contribution of contractures to my reading, but according to this reading, he falls here.
Yeah. I mean, dehydration. You say 5 and 10 and 15% weight loss. Okay, it may not be exactly right. What I am trying to say is that yes, if the person wants to know how to measure, yes. But if the person knows why you measure, I have already said it doesn't matter.
If you want to make a trouser for him, then probably you will have to grow along. Otherwise, it will have different length. But otherwise, it won't matter.
Investigate to go for the hemogram, whether child is having anemia or iron deficiency. Anemia is more common, and if child is having some feeding problems, that time I have to look for the other these things. Then after that, I would go for visual assessment of the child also. Then auditory assessment, whether child, because he is not speaking well while examining, that time I want to know about what is his auditory. Then after that, I will go for some imaging to localize the lesion and what structures are involved, to know about the prognosis of the child. Something.
Imaging will cost a lot of money.
Well, imaging, I'm not very keen. You have the child in front of you, you have the history, and you can predict what's going to happen. You are not much interested in which areas of cerebral cortex or other parts of the brain are involved just now. You have made a reasonable guess as to what are going to be the final achievements of this particular child, and an expensive imaging is not going to really add. If you are worried about prenatal problem in the form of CNS malformation or something like that, then it was worth the while.
Just imagine that all neurologists would image, many examiners would like you to say imaging. The question is, one fellow in the exam might say, why imaging? So what I would say is that an imaging may be considered. It might kind of rule out anything that I did not suspect, like any conjugation. However, it's not cost effective in this child because it will not change my management and my prognosis. I have taken care of an examiner who is rural based and say I don't have CT, and I am also taking care of the great neurologist who cannot opine without the imaging. So I play safe, okay, because unnecessarily you are stressed if you say, oh, no imaging? Which kind of era are you in? Okay, it shakes you. So what you said is right, what he said is right, and therefore I would say that imaging could be considered, though not very likely to help me in this child, except maybe some minor malformation that I might have missed it clinically. However, it's not therefore cost effective. That means I have brought in cost also and will not change the management.
And in the same breath, the absolute indications in a CP are a CP with a normal head circumference, normal birth history and family history of CP. These are situations where you have to do imaging.
Absolutely.
In a CP.
Because there you are not expecting the routine run-of-the-mill CP, and there is something, management.
This approach should be multidisciplinary. We will involve orthopedician also in this case management, then some support groups, NGOs also, then pediatrician, and all this teamwork will help to go for child's assessment and his well-being. We'll also go for the physiotherapist and occupational therapist. Early stimulations are helpful in this child. We will help him to make a walk by giving the early stimulation like tactile stimulation, auditory stimulation, visual stimulation, and some postural.
What's the idea of a physiotherapy?
Physiotherapy will help to reduce some degree of spasticity in this child because tone is raised, and that may lead to hampered his postural that's why we have to go for regular physiotherapy, and it will decrease the spasticity, and child can walk.
So class-like spasticity will disappear after physiotherapy?
Not exactly disappear.
Then why do you say it will change?
Physiotherapy helps to prevent contractures. So if the child is having spasticity, by physiotherapy, we are making the muscles continue to work so that the contractures do not occur. And for occupational therapy, we are trying to achieve certain functional ability for the child, by which he can carry out his activities of daily living, like feeding and.
What's the occupational therapy doing in this child? You said occupational therapy.
Occupational therapy they can help us in fine movements of the child, as he is having some degree of dystonia and the child is not coming to the object properly. They will help us in the form of like doing some fine movements, like and which we can and coordination also, hand to mouth coordination. Also, the child may get self-independent for feeding and all.
So occupational therapy makes the child function as independently as possible. That is my occupational therapy. So that's what. What about an anticonvulsant in this child?
Child is not having convulsion.
Will I do an EEG?
Actually, mother is not complaining of any abnormal movements like convulsion. That time I don't consider EEG.
You know, brain damaged child is very highly likely to have a seizure disorder. And what's the difference between convulsion and a seizure?
Seizure, it is a epileptic form. It is due to the epileptic form discharges, and convulsion is a clinical presentation.
Difference between seizure.
So seizure is always a manifestation of the underlying convulsion. A convulsion may or may not manifest.
Seizure is just abnormal electrical discharges in the brain, and convulsion is the presentation with tonic, posturing and the other things.
What other management? Neurological management. Any extra neurological management?
In child is not talking properly, that time we have to look for whether there is any speech defect, whether child is having any dysarthria, other speech disorder.
That's a part and parcel of a neurological.
Sleep disorder also we have to take care of in this child, because this child must be having some abnormal behavioral problems also.
Right. So that's a neurobehavioral issue. That's one big issue. Yes, you are right. Behavior, etc. You may have an autistic behavior, etc. So,
orthopedic, if a child develops contracture and may require tendon lengthening.
Any other?
Management of constipation and prevention of UTIs.
So since the child might be bedridden, then we have to also manage the dermatological complications in this child.
So don't forget GER. Gastroesophageal reflux is so common. Constipation is a rule. Because of that, UTI could be a possibility. A hygiene of skin is an important issue. So bladder, skin, bowel control. Vitamin D, the most common problem today. He's going to lie down there. His bones are going to be weak. He will have specific vitamin D deficiency. So take care of all that. And then, of course, lastly, the nutrition. How are you going to feed this child? How safe is to feed by spoon or by the tube or whatever? And I think those will be the thing. Right? Lastly, what's the prognosis of this child?
Management of dystonia in these patients.
Yes. So the question is, if the dystonia is so big, how will you manage that? Yes, that's another drug therapy as well. Whether you want to use any or even a Botox, etc., to reduce the muscle tone. Yes, that's another area of neurological management.
Dental hygiene also we have to take care of.
Prognosis?
This child till 2 years he is able to sit without support also. He may walk in few days, and he is following object, and he is interacting with the examiner and His social milestones are quite well. There is no social impairment more.
Child achieved sit without support, so he may be able to walk. He's interact with the others, so cognitively is also improve. We have to explain parents that child is not as normal as other child, but he's with the help of some physiotherapy and occupational, he's achieved daily work.
Prognosis.
For prognosis, I need to understand whether it is educable or trainable. Once we put in that category, then we have to prognosticate accordingly. Involved category he is in.
Sorry, I didn't get you.
Whether he, after having comprehensive examination assessment, for prognosticating point of view, I will say whether it is educable or trainable, and accordingly I will prognosticate.
I think the prognosis is simple. Prognosis for life first. Life seems to be secure. Then prognosis for quality of life. What is quality of life? Two things: mobility and a cortical function. Would he be mobile? That's what I need to guess. And what kind of a cortical function I expect? What's cortical function? Will he be educable, or will he be just trainable, or will he be untrainable? Fine. That's the cortical function, and that's the mobility. That's all that you want to talk about largely, right? Otherwise, theoretically, yes, he may have an aspiration, he may have a pneumonia, but so your prognosis would be, if taken good care, okay, his life seems to be secured. His mobility is a bit questionable at this point of time, but I would know in the next 3 months whether he is likely to walk, and he may need lot of support, but he will walk. And then the quality of life, in terms of his DQ today, it looks like that he could be at best a bit trainable, but he may not be educable. This would be the kind of yeah.
That's 100%.
Sir. Dr. Ambekar, sir.
How will you counsel the parents?
So there is a question for you. They are not happy with any of the answers we have given. You are to tell us what is the difference between seizure and convulsion. By Dr. Ambekar, sir. No, sir, it's to be given by you.
Seizure is an electrical discharge. A convulsion is what you see. Exactly. So you may have a non-convulsive seizure. That means he will need an anticonvulsant also. But you don't see him a convulsion. So that is what it is. You want to say something?
Same thing. Second thing, I didn't get the answer for whether we should do the EEG or no EEG. I think not doing EEG would be better than doing EEG, because sometimes we may get false positive EEG. So I think that would even the not doing EEG will be better.
I would agree with her that there is no need of an EEG. There are obviously no convulsion. Fine. If he convulses, we'll look at it. That's the way I would look at that. And suppose he convulses, why do you need an EEG? You are going to give an anticonvulsant.
To substantiate the seizure activity, number one, and the type of the epilepsy.
So if the mother is not properly able to imitate what kind of seizures are there, and not able to give a proper history, like if the child is having infantile spasms, the treatment would be different. So for different seizures, the treatment is different.
Yeah, I mean that to put it more refined way, to know the type of seizure.
And if we get to know the type of the seizure, and also while stopping therapy, we can the baseline EEG that we do before starting treatment will be helpful while deciding about stopping or reducing the therapy. According to the history and clinical examination, if we suggest it's a static encephalopathy, that time probably this child having convulsion, and I don't want to put the burden for economic constraint to the parents like doing all these investigations.
Sir, I think I beg to differ there, sir. I think EEG is important, is as important as other points of management, because say the child is having an electrical activity which is not manifesting as convulsion, that will further worsen the prognosis of the child, because that will further decrease his further cortical development. More the seizures, the cortex will deteriorate more, and the prognosis will be more guarded if there is an electrical activity.
What he's trying to say is that I will miss a non-convulsive seizure. But non-convulsive seizure is not to be missed clinically. Non-convulsive seizure in this child is, the mother says, suddenly he goes blank for a while and then he comes out. Non-convulsive seizure could be just an episode of paroxysmal drowsiness or non-responsiveness. That is the thing. Okay. Even in a known epileptic who is well controlled by drugs, he could have a non-convulsive seizure. So that is what it is.
Sir, but your last statement was the most important one. Non-convulsive seizures occur in a child who has seizures and he is under treatment and he presents as non-convulsive seizures. It is not a de novo entity. If this particular child has nothing to suggest seizures, I am not very keen to do an EEG. Unless the EEG is grossly abnormal, I am not going to. Because remember, anticonvulsant medications are not without side effects, and minor manifestations in the EEG here and there are difficult to interpret. If he has a gross abnormal EEG, I am not likely to get a normal, sort of a clinical manifestations.
I'm sure you are not going to be failed by saying yes or no. You will have to defend why you said yes or no. Take the mic, take the mic, take the mic.
The last thing is to know the type of seizures. I don't think in this case it is that important to know the type of seizures. It is there when you are not having a CP child where you want to differentiate which type of seizure the child is having. Here we have an obvious birth history. You are quite sure he will be like a generalized, and so you can treat.
So this is not true.
Here's an answer to you. Yeah.
This is uncertain, sir, because the semiology of seizure in a child with CP will not remain constant. It might evolve. Like in the infantile period, he might have infantile spasms, but as he evolves, as he grows, it might go into a West syndrome-like phenomenon. So we can't particularly
So
say.
we cannot keep him treating with eptoin when he is having infantile spasm. So we have to know the type of seizure.
Fine. And I think when you say generalized seizure, there is often a small focus from which it starts. And when you said a focal seizure, it could be really a focal with a generalization. So you will not be able to go by that. So it's easy. I want to say EEG, I will defend my EEG. If I say no EEG, I'll defend my no EEG. I think both are fine because none of us know clearly what it should be the right answer.
So would you still recommend neuroimaging? Because there is a blame game between the pediatrician and the obstetrician. Would it help in that way?
Well, all that he means is that if you demonstrate a kind of a birth asphyxia imaging modalities, then obstetrician is at fault. I think that's another legal issue, yes. But what we are trying to say is that we have already said that CT can be considered, however it will not change my management and it may not be cost effective, and at the most it may show me some surprise small malformation which will not mean anything to me. I think that will be the best way to go about it.
We'll go on to the next case.
Counseling from you.
Well, counseling, all that I would say is that, look, your child has had some problem because of which the brain is not growing as much as it should grow. But it's still growing. And we don't know at the point of time how much he would be able to achieve, but surely he is going to achieve something more. He will do much better if you kind of intervene the way I have explained to you, like a physiotherapy, occupational therapy, the rest of the management, which we will get the best potential out of him. At this point of time, we will have to wait and see how much potential he has. Add on to say that even a normal baby's potential is not easy to make out. So don't worry about it just now. Just now let us do all this and come back after 3 months to see how much improvement we have got. Depending on that, we will be able to guess over time what would be his likely potential achievement. So keep it open. Do not blame anybody for this. Okay, do not say that he will never improve. Otherwise, like earlier I said that a Down syndrome, okay, counseling, atlantoaxial dislocation, sudden death and leukemia if he survives. No, not that. He never gets that for me for counseling, right? Yeah.
Thank you, Rajesh. We'll have the second case. Yeah.
Raval, 9.5 years old, male child, second by birth order of 2 siblings, born of non-consanguineous marriage, Hindu by religion, Raval by community, residing at Ghatkopar, hailing from Rajasthan, brought by an informant being father, with the chief complaint of pallor noticed by parents in 15 days, yellowish discoloration of eyes in 15 days, and breathlessness, generalized weakness in 15 days, and breathlessness in 2 days. Patient was apparently alright 15 days back when his parents noticed pallor, which was insidious in onset and gradually increasing. Parents also noticed yellowish discoloration of eyes in 15 days, which was gradually increasing in intensity. Associated with history of generalized weakness in 15 days and breathlessness in 2 days, which was in the form of increased respiratory rate and depth of respiration, especially on exertion. There was history of passing of dark colored urine, that is reddish to blackish colored urine, 2 to 3 episodes in the past 4 to 5 days. There was history of backache, bony pains and leg pains present. On inquiry, history of abdominal pain present on and off, which was dull aching, located in the right upper abdomen, not associated with vomiting or any altered bowel habits. There was no history of pedal edema, palpitations or abdominal distension, no history of high color, that is yellowish urine or pruritus or any clay colored stools, no history of any gallstones or surgical interventions in the past, no history of bleeding from any other site, no history of similar complaints in the family, no history of joint pains or skin rash, no history of loss of weight or loss of appetite, no history of COX or COX contact. There was history of similar complaints in the past when he was worked up and he was told to have some blood-related disorder and was asked to take regular transfusions. Since then, the patient is on regular PRC transfusion every 3 to 4 monthly and has been receiving regular transfusions. Apart from transfusion, child is not put on any oral medications for the same. Birth history, it was uneventful, ANC registered and immunized. There was no ANC related complications. It was a full-term vaginal hospital delivery. There was no neonatal or postnatal complications. Immunization history is complete as per universal immunization program. Developmental history, the child studies in 5th standard. His average studies and developmentally appropriate for the age. Dietary history, he has adequate calorie and protein intake. Family history, family and socio-economic, there is no history of any similar complaints in the family or any history of PRC transfusions in the family. Social history, they belong to class 4 according to the modified Kuppuswamy classification. Go to general exam.
Okay, so if we were not given the history of receiving frequent transfusions in the past, how would you analyze the presenting complaints history of last 15 days? If you were not given that history, if given that history, the story becomes quite simple. So somebody to take up the analysis of the present 15 days complaints. Yeah.
Sir, anatomy of the lesion, it is intravascular since the urine is red color urine, red or brown colored urine, intravascular, and it could be hemolysis etiology, and it is suggestive of an intravascular hemolysis since 15 days.
Okay.
Hemolysis. And with yellowish discoloration of eyes without any history to suggest obstructive jaundice, which is suggestive of an unconjugated hyperbilirubinemia.
Okay.
9.5-year-old male child, and the complaints are since 15 days. Then we would think of what can cause all this. So it could be some medicines that could have been taken which would precipitate a hemolysis. It could be a membranopathy, enzymopathy, or a microangiopathic hemolytic anemia. And it could also be then we can think of any autoimmune hemolysis. And then finally the complications, whether there are any complications of the illness.
To make it more simple and basic, I will start from that this child has acute liver injury. Though there is no history of fever, but I would definitely look into that. Acute liver injury. He has progressive pallor. He has breathlessness. He has jaundice. So I definitely would like to have a look on the liver first, and then all those things, though there is no history of fever.
So if there is liver involvement, there is hepatocyte involvement, there is nausea, vomiting, and nausea and vomiting associated is like with a viral hepatitis. There is a prodrome is always there.
You are right, but I personally believe in the given set of Indian scenario where we know that hepatitis is very common, I would like to definitely rule out that first and then think of these more uncommon things.
So for the acute liver injury to cause such a severe pallor that the child is having breathlessness and weakness, which suggests that there is a sudden onset of hemolytic anemia, which has increased in severity over the past 15 days, that the child is having breathlessness and since the past 2 days. So I would go against liver. And
since this is a short case and we are already close to 8 o'clock, I'll ask you one question. Yes.
Sir, acute liver, as sir said, a child would be very sick. Who is having acute liver injury, he will be sick. So what is important to be asked is, with the episode of pallor that is noticed over a period of 15 days, along with the icterus, the discoloration, how well was the child before the onset of breathlessness? If the child has been sick in this entire period of the symptoms, then probably we are dealing with the kind of pathology that sir pointed out. But a child with just liver injury will be more sick as compared to...
Can you explain to me why should a liver injury present as progressive pallor?
No sir, it won't present.
So if the presenting complaint is, first complaint is progressive pallor, tell me which liver condition will present with progressive pallor?
It is a chronic liver disease which can present with a progressive pallor, but not this, the onset is pretty early. The duration of pallor is very less compared to...
Sir, in this case, we can think like similar history is present since 3 to 4 months. Either that can be a separate episode or this is the same repeated episode. So this can be a chronic disorder or an acute problem. We can differentiate accordingly. Our depends on that. So if a liver is involved in this system, either we are thinking a liver problem or a hematological problem. So liver is less likely, it is unlikely because liver will present liver problem will present acutely, and if acute problems come, it will have a signs of hepatocellular involvement in the form of jaundice, and it will be a conjugate. So in this case, blood will be the site of involvement, and in blood it will be extra vascular or intravascular problem. Extravascular problems will present acutely, and intravascular problems like some membranopathies or enzyme defect, then they will present chronically. Enzyme defect will again present acutely.
The type of jaundice is also important.
hemolysis.
If it is suggestive of an acute hemolytic process, then it is just a yellowish tinge. But if it's a liver, the cause of jaundice is because of a liver pathology. It's more of a deep pathology that is more deep jaundice that is more important in a kind of liver pathology.
My consideration for keeping the liver in differential is that we live in an area where the hepatic injury is very common.
No, sir,
I would not live giving a consideration for, of course, that's not on the top of the list, but my thinking will be, I definitely would like to rule out liver injury, and
sir,
then we'll progress for all this. This is
agree.
what I mean to say. Other differentials are also on the list. This is
fully agree with
what
you,
I mean
sir.
to say. We cannot have a patient with icterus and not considering liver injury in our setup. This is what my message is.
Child doesn't have any fever, so we first rule out the infective causes. We know, not considering the past history of repeated conversion, past or repeated blood transfusion. Child having pallor and hemolytic cause origin first we consider here. Then further we rule out the further causes.
In the complaints, I think there is high colored urine, right? High colored urine. Red color urine. Sorry.
Sir, considering that this being as a first episode, with just the history of progressive pallor with a gradually developing jaundice, the leading to such a severity of the pallor, leading to probably a generalized malaise or a weakness, for which he required a transfusion later on. with such an acute onset, I think it is a hemolytic anemia unless proved otherwise, which can be because of any cause, membranopathy, autoimmune or
No acute liver disease presents ever with anemia. Okay, that's number one. If it presents with anemia, then there is a lot of hemorrhage, obviously, like hematemesis, melena, etc. So those histories are predominant more than pallor. The only condition where an acute liver disease comes with anemia is a combination of a liver disease with hemolysis. Again, therefore, hemolytic anemia. Like a Wilson's does that, but not at this age. But that's an exception, which again means this liver disease has presented with anemia because of hemolysis. So first we will say this is an acute hemolytic episode. Okay, that I think we are very clear. What you said was there is an intravascular hemolysis. Does intravascular hemolysis cause jaundice? Why did you come out with intravascular hemolysis first? And would that cause jaundice?
Yes, it would cause jaundice. Till the time there is no ineffective erythropoiesis and the RBC is hemoglobinized, there will always be a icterus when there is a hemolysis.
The point is that acute intravascular hemolysis will have jaundice where it will be an acutely sick child. We need to look at that. If this child has an acute intravascular hemolysis, it's an emergency. It's an acutely sick child. So we will go by that and say, how sick is this child? Okay. Now, to begin with, therefore, we will say this is definitely an acute hemolytic jaundice. Question is, forget the transfusions in the past. What's the cause of this acute hemolytic jaundice? We will take up that now.
Any preceding factor like stress, infection, drug history is very important in that case. That can be caused.
There are two important causes of such acute hemolysis. First, either there is a sudden decrease in production of the RBCs in bone marrow, or either there is a destruction in the periphery like in the liver. There are with preceding problem.
Sir,
so you would have said that this acute hemolytic anemia could be an acquired hemolytic anemia, acute, or an acute hemolytic crisis of a known congenital hemolytic anemia. So that's the two things. Is it an acute acquired hemolytic anemia like an autoimmune hemolytic anemia? That's what he said, infection, etc., whatever. Or is it a hemolysis of a chronic hemolytic anemia? That's the way we would go by. And there you will go by the past history, whether that is so. An acute hemolytic anemia acquired is generally an immune-mediated acquired hemolytic anemia, not common at this age. And to that extent, we would say that past history of some anemia would make us to say acute hemolytic presentation of a chronic hemolytic anemia. Having said that, then which is this one that is presenting like that is the next question. So we will take up that question.
Which chronic hemolytic anemia?
A chronic hemolytic anemia presenting with hemolytic crisis, I would like to think of sickle cell disease.
Apart from sickle cell anemia, other chronic hemolytic anemias like a membranopathy, a G6PD deficiency, or a hereditary spherocytosis should also be considered. That they have triggers like use of some drugs or infection, which wherein the acute episode can get precipitated.
But G6PD or these kind of enzyme deficiency, recurrent transfusion rate will be lesser than in a
I'm not considering the transfusion rate. I'm just considering chronic hemolytic anemia presenting with.
Would a sickle child susceptible to G6PD deficiency? Yes, the answer is yes. So just to make a point that yes, so in mind that what you are saying is that, so why did you pick up on sickle only?
Because there is history of bony pains, backache, and
We all know that that's not a common type of a presentation. Far more presentations, the vaso-occlusive crisis, sometimes maybe a chest syndrome, maybe a splenic sudden severe pain, etc. Sometimes an aplastic crisis, but not so commonly a hemolytic crisis. So she will bring up sickle only because there are other things. Do you think it's a sickle cell liver disease? Yeah, now you are saying liver disease with anemia. Now she is saying sickle with liver disease. So can this be a liver disease? Sickle, yes. A sickle hepatopathy.
In a sickling crisis, there can be hepatopathy, but with treatment that would recover with supportive care.
Sir, and the children are with sickle hepatopathy are sick, and the pathophysiology.
In sickle cell, child will be very sick. Sick looking child.
And so the pathophysiology for a sickle hepatopathy is infarction, vaso-occlusive infarction, and there will be a tenderness will be a very good will be a very prominent presentation in the.
Sickle hepatopathy is not an acute condition, it's a progressive condition because of microinfarcts, which is there because of hypoxia, progressive hypoxia and sequestration. So it's not a very acute when the patient comes with sickle hepatopathy. And yes, there is an entity called a sickle hepatopathy, the reason being this one, number one. Number two, the sir said G6PD with sicklers. Yes, sickle cell is known to have G6PD also. So both the things are known to occur very frequently, not infrequently sicklers.
But what about the tenderness, which is a very important part, because acute abdominal syndromes are very common in sickle cell, whether it is mesenteric infarct, whether it is splenic infarct, whether it is liver infarct. So pain will be one of the cardinal symptoms in the presentation.
Yes, of course, this is all because of vaso-occlusive crisis of either areas, either mesenteric or otherwise, can have pain, abdomen, sicklers. That's fairly common. But it will depend upon the degree of sickness the child has. If this is acute catastrophic condition, yes, the pain would be on the other side. Otherwise, progressive low dull leg pain we can have in the sicklers also. Not only in the bones, it's not specific to bones, we can have anywhere, wherever we have hypoxic injury caused by sickle cell.
All that you would have said is, if this child has a hemolytic anemia, he has no business to have another pathogenesis of a sickle cell hepatopathy. Two pathogens are totally different. So why are we mixing the two at all?
Exactly.
Okay. So this is not sickle hepatopathy. Anyway.
I belong.
Huh? Yeah. So we'll get the.
I just want to quote one sentence from Boyd, the first line in the topic of jaundice. There is no symptom which points directly towards liver than icterus, but yet the liver may be totally innocent in the case of icterus.
Rajesh, so there's one doubt which has come from the exam point of view. In such chronic diseases, do we start with directly with the chief complaint, or we say that a known case of blood disorder presenting for the exam?
No, you start with the presenting complaints right now. Anybody wants to examine this child? Come, somebody should take the lead.
Also, in general, what I want to say, a combination of pallor and icterus may be seen in many diseases. In a hemolytic disease, along with icterus, the pallor is 3 plus and icterus is 1 plus. While in a hepatic disease, the pallor is 1 plus and icterus is T plus. Because with so much of hemolysis, you get so much of icterus. While in the hepatic disease, it's only the icterus which dominates the scene, and pallor may be mild incidental finding. So remember, when you compare pallor, 3 plus pallor with mild icterus is hemolysis, and 3 plus icterus with 1 plus pallor is hepatopathy.
What pallor or bleeding is a hematological disorder till proved otherwise. Okay. And there is nobody who presents with pallor and no hematological disorder. Yes, hematological disorder because of something. It could be a mycoplasma pneumonia with anemia. That's a different story. Which two other systems to bring together? It's a question. You have something to say.
Yeah, another important thing to remember, this child was a multiple recipient of the blood transfusion, hepatitis B infection. Overt, but yes, to be kept in mind. Very important.
Come, somebody volunteering. One or two people come. Last time she came, or you want her to come again. She's all ready.
Injury.
Come, somebody. You are depriving yourself. Yes. Come on. Easy. Come, very good. Come on, start talking.
On inspection, child is conscious, looking interested in surrounding, slightly apprehensive.
Just one point. You have already a possible diagnosis. Your general examination should focus on those issues. He is conscious, yes, I accept. So focus on those issues which are important in general exam.
Child looks malnourished.
Better word for that?
Poorly nourished. Not well nourished. Undernourished. Child is undernourished.
Malnutrition is both overnutrition and undernutrition.
I wanted to highlight on the growth of this child, not even nutrition of this child. I have a chronic hemolytic anemia on card. Growth is an important parameter. Yes, he could be malnourished as well. I want you to say whether he is not grown well. That suggests chronic hemolytic anemia.
We may not have paid attention to this, but we talk of growth and nutrition, and there is a difference between the two. So we tend to talk of nourished, but we fail to realize growth means we are talking of height, and nutrition we are talking of weight. Means crudely I am saying.
Not well grown child with vital stable at present. Not well grown child.
Quickly, with relevance to our suspected chronic hemolytic anemia and that too possibly sickle, which we have thought of on history, one was growth. Now, on the face, what do you want to look at?
Pallor, icterus, and skull.
So, hemolytic faces, pallor, icterus. Comment on these three quickly.
Head size appears to be, there is frontal bossing, no malar prominence, depressed nasal bridge, no dysmorphic faces, there is pallor, icterus.
So, would you call this hemolytic faces or would you not call it hemolytic faces?
Yeah, we can call it.
That is because you know the diagnosis. But suppose I didn't tell you the history, then are you convinced this is hemolytic faces?
Not sir.
So how do you explain that? That means our diagnosis is gone. It's wrong.
So he is taking regular blood transfusions so that we can
okay,
tell.
Very good.
So then relevant respiratory rate, that is at present he looks tachypnic with there is some suprasternal retraction but no use of aleknese, and there are visible pulsation in the suprasternal areas and even supraclavicular areas. I have to expose to see the other chest retraction and other pulsations. Otherwise,
so what other quick inspection findings that you are looking
bony
at?
Swellings,
Any bony swellings, any digits that are swollen?
digits.
Yeah, respiratory rate is said. Ulcers on the lower limb. Okay. Any hyperpigmentation? Fine. Now quickly do the systemic examination and tell us what you are getting.
We can see the bony tenderness also in a general examination. So I will like to examine the abdomen of this child. First,
I think you quickly do it and then tell us.
Actually, I have to expose the child up to thigh. On inspection, shape of the abdomen is normal. There is no distension. There are scar mark present in the on the both side in the left and right side hypochondriac region. Umbilicus is normal. No generalized fullness.
What do you suggest?
Sir, there may be some
branding
therapy.
marks. Very good. Yeah.
And sir, hernia orifice is
yeah. Go on.
normal.
Go on. Examine.
Palpation.
Yeah.
On superficial palpation, there is no tenderness, no guarding, no rigidity. I will palpate for organomegaly for liver. Sir, liver is palpable around 8 to 10 centimeter below right costal margin with sharp margin, firm consistency and smooth surface, no tenderness.
In the same breath, you should say where is the liver dullness so that you get the liver span. Okay.
So left lobe of liver is also palpable and tender. Spleen is palpable, 4 to 5 centimeter below left costal margin, moving well with respiration. Anterior notch is felt. It is hard in consistency, non-tender.
Any findings in any other systems or any findings that we have missed? Okay. So now you quickly construct your diagnosis.
A 9.5-year-old male child with a background of past history of regular blood transfusion, acutely at this time acutely present with a history of pallor, generalized weakness, icterus and breathlessness. With on examination with hepatosplenomegaly, I will like to consider is as a chronic transfusion dependent chronic hemolytic anemia and associated with bony tenderness and history of pain in joints. I will keep my first differential diagnosis as a sickle cell anemia, and
it's a liver disease only. What you were saying, firm liver, spleen firm, chronic liver disease with portal hypertension. Why are you bringing in hemolytic anemia? Which hemolytic anemia has a large liver, firm liver? Not accepted.
So the hepatosplenomegaly is because of extramedullary hematopoiesis.
It's firm. Okay. It's a cirrhotic liver. Okay. No question. It's a liver disease.
So generally chronic liver disease will not present with the transfusion dependent anemia.
It's both. Somebody has been giving transfusion and causing hepatitis B or C and now getting into a chronic liver disease. Just now he has a chronic liver disease. He has got a firm large liver and a firm large spleen. Okay, he has a compensated chronic liver disease.
They have other signs of liver cell. If they have gone into cirrhosis, they have other signs of liver cell failure.
Yeah, what other sign? Growth failure. No hemolytic facies. Growth failure is a chronic liver disease.
Progressive failure in the history.
if we are suspecting hepatoma? No. Why should it be progressive? Chronic liver disease can go on for years.
There must be history of hematemesis or any bleeding manifestations to rule out the portal hypertension also.
Don't wait for that. I am going to prevent hematemesis. Okay, I am not going to allow him to throw up blood and come in an emergency. Tell me why it's not a chronic liver disease.
No ascites.
Ascites is a compensated liver function. Ascites is the liver cell failure.
Patient with chronic liver disease will be a sick child with growth failure and abdominal distension or ascites or other signs of liver cell failure apart from...
There is no liver cell failure. It's a compensated liver disease. So,
Please use the mic.
The cirrhotic liver will not be palpable only if it is chronic. If it's chronic.
chronic liver disease is almost always unnashed. Okay, it's a rare thing to have a shrunken liver that you can't palpate. By then he's almost on hepatic encephalopathy on a deathbed. So that's not right.
Mic, please.
There is no history of colored urine suggestive of conjugated hyperbilirubinemia.
Associated with
Is that this child has not had really a chronic liver disease, does not have jaundice. Forget hemolytic anemia in this child. My findings are of a chronic liver disease. That's all I know.
So in a chronic liver disease with a palpable spleen, invariably there should be signs of portal hypertension, which this child doesn't have.
Spleen is a portal hypertension.
But
you want the veins to be there? No. You want a caput medusae to be there? No. Spleen is
hemolytic anemia spleen more enlarged than liver.
So here liver is more enlarged than spleen, right? Good.
Sir, synthetic function of liver must be involved. So we must find a vitamin D. Vitamin deficiency.
I wanted you to make a note is this liver is not firm. Is not firm liver. Spleen is firm. Okay. Look at a chronic liver disease. Spleen may not be that firm, but the liver is firm. This liver is not firm. Okay. After all, this liver is a liver of probably yesterday's cardiac failure. It's a congested liver. So it doesn't look like a nice soft liver, but certainly not a firm liver of a liver disease. And how do you go by? Compare spleen and liver simply. Spleen is a very firm in this child. Liver is just soft to firm. Why is liver? Maybe cardiac failure is treated, maybe transfusion is given, he'll come around. Okay. That's why this is not a liver disease. But in an exam, I would catch you only on chronic liver disease. Okay, you need to have a gut of that. Then you would say that if this was a chronic liver disease, I'm looking for fetal edema, hypoalbuminemia, that's what he said. But barring hypoalbuminemia, there is nothing more expected in this child. You may not expect jaundice, you may not expect. Then you would say that this child has got a hemolytic anemia, jaundice, spleen. Then why should he have a liver disease? That's what we discussed earlier. But this child has no abnormal liver. This child is an abnormal liver, but just a congested liver. Okay, wait for a while, this liver will all go down. And I think therefore, make a note of that. Simplest way to go, not a good way. Good way is to keep on palpating all livers and spleen and be sure whether it's soft, firm or hard. But one way to know is that this child has got a chronic hemolysis. Liver is taking less brunt than a spleen. Yes, liver is taking some brunt, but the spleen is taking a brunt of even hemolysis. So it is much more enlarged and firm. A liver in this child is just a cardiac failure liver.
And then after, of course, that's the main point, but after that you could use the accordance between the signs. So for example, we talked of growth failure. Now sir kept countering you on everything, but you have to correlate. So if we are saying this is compensated liver disease, then why should he have so much growth failure? If we are saying he has significant icterus that is visible, that means hepatocyte function is affected. Then why we are not having edema or ascites? So all this discordance will add to your points against the liver disease.
Chronic liver disease is a chronically sick child. A chronic hemolytic child is a happy child. So bring in all that to say that.
We can first stick to the finding that this particular child has a progressive pallor with a mild icterus That makes this particular thing as hemolytic anemia. You cannot diverge from that because it is presented like that. Now, if you want to bring in an hepatopathy, then you bring it as an additional point, but that doesn't shake your initial diagnosis of progressive pallor in a child with mild icterus, not suggestive. There is a high, never high color. So, hemolytic anemia is definitely there. Associated with whether there is hepatopathy or no is arguable. So you can't shake from that diagnosis. So don't leave hemolytic anemia, then we can argue against and for liver.
Quickly. Sir, one question I have, sir. Is the duration of symptoms also a pointer that it is not a chronic liver disease? Because the presentation is since the past 15-20 days, and to call it a chronic disease, we need a certain amount of duration, say 3 to 6 months. So even if we say that if it is an asymptomatic chronic liver disease, it won't remain silent for this long so as to present on one fine day.
No, chronic liver disease can remain silent without any, and that's so-called, the ill child, etc. Unless you really evaluate critically, you may not. So, in a child who has a history of 15 days, that doesn't mean that the liver pathology is only of 15 days. It may have been going on earlier also.
I have no doubt that the history doesn't tell you that. I want you to make a note that this liver is not a liver diseased liver. Okay, who calls it a liver disease primarily? No. But is it a hemolytic jaundice with a liver disease? That's what I'm going to ask you. So I'm not doubting history, chronic, blood transfusion, everything is clear. But when you give me the history examination of a firm liver, I'm going to ask you, doctor, I agree hemolytic anemia, but I think this child also has a liver disease. Now that you will have to counteract. I'm not doubting your ability to go by history, chronicity, duration. I'm not asking that. But I'm asking, how does the liver and spleen look like, and it does not look like a liver disease, even if you have an enlarged liver. That's the point I was making.
Now, having said chronic hemolytic anemia, which chronic hemolytic anemia? On history you thought of sickle, but now on examination you've got hepatosplenomegaly. So you've got splenomegaly, which is again sickle. You've got liver, which is bigger than spleen. So this could be thal.
It can be a combination of sickle thal also.
In a crisis, there can be splenomegaly, and he is in crisis.
Actually, spleen. So one sec, So that is sequestration crisis, which he has made a point that in a sequestration crisis you can have a bigger than earlier spleen.
Sir, even in a sickle cell anemia child, a child after 5 years, usually he won't have a palpable spleen. Usually there is a functional asplenia or autosplenectomy in children with sickle.
This child is receiving blood transfusion, so probably his spleen might not develop the autosplenectomy, and he is on a regular blood transfusion, so spleen might get enlarged in the sickle cell disease.
There can be hypersplenism in this patient. That is one more cause. Or it can be thal intermedia who was presented. That is one.
It is a transfusion dependent anemia, hemolytic anemia. It's mostly thalassemia.
Some patients may have spleen because in Chandrapur districts, they have presented.
Absolutely. There is nothing like a small spleen in sickle. It could be a very large spleen in sickle. In fact, the Indian haplotype classically is a large spleen with sickle. Don't go against
that concept of autosplenectomy is gone.
What he says is, go to that area, everybody has a spleen in the iliac fossa with a sickle. And there is no sickle thal. It's all homozygous sickle.
The additional problem in those areas is chronic malaria. So you have a combination of anemia and chronic malaria. So both is going for that. So you can have this kind of spleen very well.
So therefore,
second thing about your sequestration crisis, it's an acute event. Catastrophic event, life-threatening condition. So there are few life-threatening conditions in sickle cell anemia, like stroke, like retinal, with loss of vision, and sequestration crisis. So that is not very like patient will come and be like, it's a patient will manifestation in sudden increase in the spleen with shock. Okay. So that is the diagnosis of sequestration crisis.
So that is one. Now, any other point against thal clinically? Do thal get icterus?
Yes, sir, they can get icterus.
Thal intermedia can get icterus.
Okay, why?
Because it is actually the level, the point of destruction where the RBCs of the during the maturation of RBCs, the point where the destruction occurs is after the hemoglobin is formed in Thal intermedia. So in Thal major, it is just above, above the normoblast phase.
So the etiology of icterus in thalassemia per se is multifactorial. It could be because of repeated blood transfusion, the child has got hepatitis B and then the child can get icterus. If the child is improperly treated and with iron toxicity, he can get liver disease and then he can get icterus. So the etiology for icterus in a thalassemia, not intermediate or major, is multifactorial. So
multifactorial but not related to the hemolysis per se. Primarily in Thal, there is ineffective erythropoiesis, so no icterus, primarily. So if you get icterus in a Thal, then it is through these other reasons.
And also the frequency of blood transfusions this child was having every 3 to 4 months, but a Thal will require more frequent.
So you add up all these points to construct that this is unlikely or less likely to be Thal, but primarily a sickle. Okay.
Transfusion frequency Thal intermediate will have marked dysmorphic features. Thalassemia intermediate have classic hemolysis feces and they may have icterus, while Thal major who has received frequent transfusion may not have.
So how will you prove your diagnosis and how will you manage? Quickly, 5-7 minutes.
Sir, I will do first investigation, hemogram, complete blood count, and for proving my diagnosis, hemoglobin electrophoresis is the investigation of choice. There, I will look for HbS band. If it is more than 80%, it is sickle cell disease. And
this particular child's sickling test was done in the laboratory yesterday and was negative.
Before adding to that.
He has received the blood transfusion.
Just before the blood was given, the blood was drawn, subjected to sickling, and a transfusion was given later. Test was reported as negative.
Please take the mic.
Like fresh RBCs may not show sickling.
No, they are not.
Sir is saying that the sickling test was done before transfusion.
We always draw the blood for investigation and then happily give a transfusion. So this particular blood was before a transfusion, sickling test was negative. Not at all an uncommon scenario. Anybody who is working with hematology department?
After crisis, the newer RBC found
there has not been any crisis here.
For sickling test, freshly prepared sodium.
Excellent. You need a freshly prepared solution, otherwise you will get a false negative result. The stock solution which is there, and probably in areas which are like Bombay where you don't see sickling, it may be maybe 14 or 13 solution which is prepared many days back, not used, and you are good. So freshly prepared solution, and if the test is negative, then only it is. Otherwise it's a false negative test.
Management,
acute management. If child is present in fever, first we will give oxygen, positioning, and then the main management is blood transfusion. And
any drug?
Hydroxyurea.
Why?
And
it prevents sickling or what?
It increases hemoglobin F.
And sir, painkillers to reduce his pain and suffering.
To increase hemoglobin F. So again, the Indian haploid has often a high F as well in a sickle. So one doesn't know really how it's going to help. But yes, the reason why you give hydroxyurea is to increase the HPF. Any susceptibility to infections?
In the history, it was told he was appropriately immunized. What specific immunization you have asked for this, or otherwise, what was the prophylaxis which was put forth?
Immunization against capsulated organisms like pneumococci, meningococci,
HNC. That's what he received. That's fair. And any other medication that we would like to put on?
Folic acid and that hydroxyurea.
What about the role of penicillin prophylaxis after immunization?
it will prevent the infection.
There is role, sir. There is role of penicillin B, because even though the patient might not have, there is a functional asplenia in this child. It's not the spleen still might be there, but there is functional asplenia. So they are more susceptible any which ways.
What's called as opsonization, defective opsonization, all those things will there, and they are defective, still they will need the penicillin prophylaxis.
Is antenatal diagnosis possible?
Yes, sir. By chorionis villus sampling, there is a genetic study. We can look for the genetic defect.
Is curative treatment possible?
Bone marrow transplantation is a possible curative treatment.
Since the child is transfusion dependent, so iron chelation therapy.
Iron chelation. Because child is in failure and breathlessness is there, that's why we want to rule out the other iron 2D echo also and cardiac involvement.
We want to do 2D echo because pulmonary hypertension is very common in sickle.
Second thing, anemic cardiomyopathy also. They have, function defects in the heart also.
I think we'll stop here. Any questions to be addressed?
Sir, bone DEXA scan and densitimetry also should be considered.
Sure. So we'll stop here. Next Thursday we won't meet because it is Diwali. So we'll meet after that, which is I think 29th. For the broadcast people, the next broadcast is from Kalavati Saran Hospital, 24th
at 4:30.
At 4:30.
4:30.
It's a Friday.
It's a Friday.